Okay.
Yeah, but we're about to go live, and I'll just put up the announcement.
Okay. I can do a screen share, right?
Yep.
Oops.
Yep, we are now live. We can give it like 1 or 2 more minutes, like let everyone show up, and then we can go ahead and get started. The temperature there looks so nice. I'm so jealous right now.
Yeah, I won't lie, it is.
What were you gonna say? Sorry, I cut you off.
No, it's okay. What was I gonna say? Oh, how many people usually come or attend?
So we let students like watch the session after it's already been done as well, so that they can have participation. So typically tuning in live, we have like 200 to 300, but with a PA, we can get anywhere from 4,000 to 6,000 students. So
Okay.
overall, so I think that it's good. We'll just get started. Hello, everyone. Welcome back to Call Through Fall, and happy Thanksgiving break to those of you who have started. Today, we will be shadowing Archana. She is an urgent care physician assistant, and I'll let her take it from here and introduce herself.
Okay, hi guys. I'm Archana Patel, physician assistant. I practice full-time in Hawaii. Let me share my screen with you guys. Oh, it's disabled.
Oh, try now. Sorry.
It's okay. Okay, can you guys see?
Yes, ma'am.
Okay. All right, so yeah, hi, I'm Archana. I am a physician assistant, as introduced, and I practice full-time in urgent care, and I'm also a PA mentor. So I'm just going to talk a little bit about both of those things and yeah, kind of my day-to-day. So a little bit about me. I grew up in Georgia. I was born in India, and I moved to the States with my mom when I was a year old. My dad was already here. So I've lived in Georgia my whole life. I went to school there. That was kind of home base. I am multilingual, and those are the languages I speak: English, Gujarati, which is my native language, and Spanish. I have a Bachelor of Science in Biology from Armstrong Atlantic State University. That is a local school in Savannah. I minored in Spanish, which I highly recommend for anybody going into medicine. I think it's always good to have a second language, and especially Spanish, living in this country. My pre-PA patient care experience was a pharmacy technician. I worked at CVS for a long time. I pursued my Master of Science in Biology from Purdue. After that, I worked as a research assistant at the Indiana University School of Medicine, studied wound healing on diabetic mice who had MRSA versus mice that did not have diabetes. So studying the difference with wound healing there. And then I earned my Master of Science in Physician Assistant Studies from South University in Tampa. I was president of my PA school class, and I graduated in 2018, March of 2018. So I've been practicing for 2.5 years. I do live in Hawaii. My husband was here for residency, and so we've just stayed here afterwards. He is a hospitalist physician on island. My first job in Hawaii was as a locum tenens physician assistant on a military base. So that was really cool. Locum tenens, if you guys don't know, is like temporary job placement, basically kind of filling a gap or a need. Usually has an end date with the potential to extend. And then since then, I've done pediatrics and sleep medicine. So the most I've done, the specialty I've spent the most time in since graduation has been sleep medicine. I've done 1.5 years of sleep. And then currently I work in urgent care full time. So last thing on the slide, AP the PAC is my Instagram. It is something that I just started and I'm still kind of getting into, but I do pre-PA mentoring and I host virtual shadowing. And we have an upcoming EKG course as well for anybody who needs a refresher or just wants an introduction to it. So, what is the role of a pharmacy technician? I always share this because there are a lot of you guys that maybe don't know what you want to do, whether it's med school, PA school, something else in medicine, NP school. You may not know what you want to do. So, gaining exposure in healthcare is really important. So, for me as a pharmacy technician, I would fill patient prescriptions. As directed by the physician. And of course, you're practicing with a staff pharmacist. You're going to educate patients on programs that are available for medication maintenance. Like a lot of new drugs that don't yet have generics are expensive. So it's important to be able to educate patients on where they could go to find coupons, discounts, things like that. You are communicating with insurance companies to try to get medications covered. I definitely learned a lot about how much insurance dictates healthcare and prescription drug coverage. It's really, really sad because it can prevent people from getting life-saving medication, unfortunately. Um, Educate patients on the uses and the indications for medications. Of course, that's within your own scope of practice as a pharmacy tech. You're not the pharmacist. Learning medication indications, brand versus generic names, dosages, those things just come with time. And then gaining exposure to part of the patient care experience. So you're on the other side where the patient's already been evaluated and seen, and this is their treatment. So my why, I get these questions pretty frequently. What made me go into medicine? Why did I choose the PA path? And why did I create the platform? So the why medicine, I didn't know what I wanted to do. And then I had a cousin that was very, very sick. And so him being really sick really intrigued me. And I wanted to know more about the why, kind of understand the disease process and understand why the things that were happening to him were happening to him. And so that's kind of what sparked my interest in medicine. I didn't know what I wanted to do. I just knew I wanted to do something in medicine. So I became a pharmacy tech. And then um, I ended up with appendicitis and I went to the ER and I was cared for by a PA from beginning to end. So he was one of the only people I remember from my hospital visit. And it was through him that I really learned that there was this other provider role that I'd never heard of. Nurse practitioners I knew, nursing, of course, physicians. So I'd never been exposed to a physician assistant, and to be cared for one or cared by one was really interesting. And I was really, really intrigued because I didn't have to commit my whole life to one specialty. That was probably the most intriguing part because he worked in an outpatient clinic primarily, and he was just moonlighting in the emergency room for extra money, probably to pay off loans or something. So that part of it really appealed to me. So I went back and I did more research. One of the pharmacists I worked with, his daughter happened to be a cardiothoracic PA. So I went and shadowed her. And then it just kind of snowballed from there, getting in touch with other PAs, shadowing other PAs. So I shadowed surgical and non-surgical PAs, cardiothoracic to orthopedics to pediatrics. So there was a lot of shadowing that I did to really solidify my decision to become a physician assistant. And then fast forwarding to this year, why did I create the platform? So AP the PAC kind of came about during COVID when when I was practicing sleep medicine before and a little bit during COVID, I was always allowing shadow students in my clinic. So every month I had somebody shadowing me. And with COVID, of course, everything abruptly stopped when I switched to telemedicine and working from home. So I tried to find an outlet for students to continue shadowing, knowing that not every program would accept shadowing hours, virtual shadowing hours. And so I said, at some point, this thing is probably not going to go away for a while. So at some point, programs will likely be at least open to it. What was currently a closed door, maybe in the future would be more open. So I started doing weekly virtual shadowing opportunities for students and kind of just went from there. I mean, I I was in, when I was in PA school as president of the class, you actually get to sit in on the interviews for 2 years. So I got to see the CASPAs to the interviews to the acceptances. I got to see the resumes, personal statements, and I got kind of the overall experience as far as what's on the other side, and things that you don't know as a student or an applicant. So that part was really cool. And that's kind of the experience that I brought into what I do now, with the mentoring, and I try to expose students to a broad variety of specialists, PAs that can really enhance the overall learning experience, and also introduces students to fields that maybe they wouldn't otherwise have access to with in-person shadowing, such as international medicine, or something like street medicine that PAs or PA students or pre-PA students may not have the opportunity to shadow. For PA students, it's great because you get to learn about different specialties and you don't have to commit to a rotation for 5 weeks to that specialty unless you are actually interested. So hopefully it helps you drive your elective rotations or even your core rotations. So lessons learned as a second-time applicant. Didn't get into PA school my first time. So it is a marathon. It's not a sprint. You can't compare yourself to others because everyone has their own path, right? I mean, we hear this all the time, but it's so, so true. Online forums, they're informative, but they can also shake your confidence. Not everybody is willing to put not bad statistics, but weaker statistics out there. I mean, we all have them, right? Not all of us have perfect applications. So the majority of us don't. And I would say probably half of us are second time or third time applicants. But the forums don't really make you feel that way. The forums you read and people post about, here's when I submitted, here's when I got my interview, and I have already been accepted, while you're the one reading it and you're like, wait, I submitted before you and I haven't even heard back yet. So, and the whole point that I try to drive home is, look, it's out of your hands. You submitted, it's out of your hands. Like, you can't change anything, but you're adding anxiety. Failure or setbacks, use it as motivation, fuel it, use it as your fuel to motivate you to push forward, and start preparing 8 to 10 months ahead of CASPA opening. CASPA opens April of every year. You can certainly get your personal statement done, your resume, your CASPA experiences. These are the things that I work on with my mentoring students, because I want you to be ready to submit about 6 weeks before the application opens. Because if something last minute happens, it's just a quick thing that you have to fix. You're not worried about starting your personal statement. We don't realize how long those things take. It doesn't matter how many times you apply. Of course, it's a small sacrifice for a long-term goal. Another question I'm constantly asked is, how did you do the distance during PA school with your husband? It goes by in a flash. It's 2 years of your life versus the rest of your life. It goes by so quickly. So it is a small sacrifice for a long-term goal. Apply early. That was what I did not do my first year. I applied so the cycle goes from April to March, and I applied in November. And some schools have deadlines in March, but unfortunately, when you have rolling admissions, November is too late, because by then all the interview seats have already been given out. So especially if you're not the perfect like 4.0 or high threes student, it's really, really important for you to apply early and apply realistically. I wouldn't do just all reach schools, right? I would do a good mix of programs. So interviews, major success. We don't give ourselves enough credit for the interview, because we're like, okay, it's an interview. We'll see what happens if or whether I get accepted or not. And then there's a reason to celebrate. To put things into perspective for you, my program had 1,200 applicants, and they interviewed about 200 of us, and my class had 24. So the interview's huge, 1,200 to 200 interviews. That's huge. And, I was one of those students, I never recognized the importance of it, but being on the other side, I see it and I understand how important it is and what a big, big deal it is. Waitlist, you're one step closer. It's not an upset, because your alternative would be a rejection, which can be disheartening, but you just learn and grow from it, right? Just like anything else, just brush it off, because your focus is to become a PA. So keep working towards it. One rejection doesn't mean the rest of your schools are going to reject you that cycle. It doesn't mean you're never going to become a PA. It doesn't mean you need an alternative career. And then acceptance, of course, you have financial and mental freedom before PA school. So just don't, no studying before school, just enjoy your life. Unfortunately, travel's not really in anybody's plans right now, but when it does become, when we're living in a COVID-free world, definitely travel and take that time, because PA school is a huge sacrifice. And be that guiding light to other students who were once in your position or who are in your position. Okay, so what is a physician assistant? This is a super common interview question, and I do think it's a question that's really important and is often not answered appropriately. So a physician assistant is an advanced practice provider. So we obtain histories, we do physical exams, we can order and interpret labs, and imaging. We formulate treatment plans, prescribe medication, and we can also perform minor outpatient procedures, and we first assist in the operating room. We're trained as generalists, so we can treat from pediatric to geriatric. PAs are very, very versatile because we're not expected to complete a residency program when we get out, and we're not limited as to what age range we can treat, which is what kind of differentiates us, along with the medical model of learning, differentiates us from nurse practitioners. And then the versatility differentiates us from physicians, because we can get up and switch specialties, just like I shared with you in the last 2.5 years what I've done. So we are very, very versatile and can be placed in any specialty or setting, as long as they're willing to train if we need it. We do practice a balance of autonomy and collaboration with a supervising physician. Autonomy is determined by the state. So for the state of Hawaii, my physician needs to be a phone call away, but he does not need to actually be physically in the clinic. He does not have to see every patient after me. That varies from state to state, or it can vary the degree of autonomy. But I really do appreciate that. I'm the only one in my clinic. My day is an 8 to 8. I work about 14 shifts a month. That's considered full time, given the 12-hour days. And it's just me. I have, in my particular clinic, I have one medical assistant, sometimes two, and I have 2 front desk staff that check patients in. And my group has, we have a group of, there's 3 PAs, and there's like 7 physicians. So it's a group of 10 of us, and we have 6 clinics. The company has 6 clinics. And PAs, most importantly, are so instrumental in bridging healthcare gaps between medically underserved and quality medical care. We know there's a big healthcare disparity in this country. Unfortunately, cost and what you can pay drives a lot of healthcare. And hopefully we're working towards change on that. But PAs are very, very instrumental, because we are an extension of physicians, and we are able to deliver the same quality care. And so we are very, very instrumental in closing that gap. So specifically, what does an urgent care PA do? So broad scope of practice, of course, any specialty. You have no idea what's walking through the door. It's like going to the ER, right? You're not going to have 2 days that are exactly the same ever. You do address anything from rashes, like what's on the slide, to ear infections, chest pain, to laceration repairs. Certain things that are beyond your scope, I mean, there's always the emergency room, right? So urgent care is kind of the in-between, between a primary care and an emergency room. During COVID, we do COVID testing, and during this COVID period, we are seeing a lot more primary care type of complaints, people coming in to have earwax removed, or coming in for chronic things that have been going on for 6 months, or coming in for medication refills. I mean, those are things that we generally do not do in an urgent care. Routinely, every now and then that's okay, but routinely, not really urgent care type of things. However, with COVID, most primary cares have gone to telemedicine. And so, if you have earwax or you need somebody to look at you in your ear, they can't do that over a computer. So they walk into urgent care, we take care of it, and that's it. I do encourage primary care follow-up for that, but if you can't get in, we're always open. That's what we're there for. So as far as other procedure type of stuff, we do start IVs, we drain abscesses, we repair lacerations, toenail removals, mole removals. We do biopsies as well in the clinic. So things like that, STD checks. Workers' compensation, we do workers' comp cases as well. Those get very, very intricate and very tricky, because companies want to know every little detail about every little thing before they agree to pay for it. So those are also important. Medication refills, like I said, bridge therapy only, because we are not primary care. I don't manage diabetes. I don't manage high blood pressure. I don't manage high cholesterol, things like that. That's what their primary care is there for. We try not to do routine blood work, but if a patient comes in and they haven't had any blood work done in 5 years and they tell me they don't have a primary care, I'm going to order basic blood work, and I do tell them sometimes insurance covers it, sometimes it doesn't because of the setting of an urgent care. But if the patient's okay with it, I think it's worth doing, and we might catch some disease or might be able to prevent disease. So we do some routine blood work very, very occasionally. We order labs, we order imaging, we do call patients to follow up. So for workers' comp, for example, you kind of become the primary care for that patient because they're not allowed to go see any other provider for the same case or same injury. So I'll see them present, I'll order the labs, the imaging, call them if it's like a hand injury or something, or bone injury. If there's no fracture, but they keep having the pain, okay, maybe now they need ortho, maybe now they need an MRI. I mean, I do order that stuff, in which case you do see the patient more constantly than you would for the typical urgent care patient. And then patient education above all, and this is not urgent care specific. This is just you as a provider, you as a PA. Patient care or patient education is extremely important. So we do a lot of that as well.
So I'm like looking at the questions, and there's some really good questions in here relating to what you do in a urgent care setting. Someone asked, do you think a PA would feel unprepared if they went into urgent care right out of PA school? Would you recommend working in another specialty first, as you did?
So that's a really good question. And that's a question I get commonly because PAs are highly saturated in surgical specialties, primary care, and emergency medicine, if I had to pick top three. I don't know those statistics specifically, but that's what I would say. So is it difficult in urgent care? It is stressful, I will tell you that. When I got out of school and I worked on the military base, that was my first job, right? It was the 3 months on base. When I did that, the military base was kind of a primary care clinic. So they functioned as a mini urgent care the first 3 hours of the day, and then the rest of the day were set appointments. So I actually started out in primary care-ish and / urgent care. So I got a lot of that experience coming out, but yes, it was nerve-wracking. The difference is that in the military, you have medics that are very, very highly trained to go on the front lines. And it's a different position, but similar to that, you have MAs that are very, very skilled, in the civilian world. So I would say in the military base, there was a lot of support in the sense that they know how to do a lot. Like I didn't have to do a toenail removal. I didn't have to do joint injections because if I said this is what needs to be done, they were trained to do it. In an urgent care setting as a civilian PA, in the setting, I would be doing that stuff myself, toenail removals, I'm okay with. Joint injections, personally, I'm not super comfortable with them, so I don't do them. And so I choose my own scope of practice in that sense. There's not a lot that I can't do or don't feel comfortable doing, but if I don't, I just refer them out. So yes, coming out of school, it is definitely nerve-wracking because you do have to be able to recognize what's emergent and what's urgent. What can you take care of now and send the patient home with versus what needs to go to the emergency room? You really need to be able to tell the difference between the two. I do feel like I kind of came out kind of as a semi-new grad when I started urgent care full-time because I came from sleep medicine. Any specialty pigeonholes you, right? You go from general practice that I did for 3 months. And now I've only done sleep medicine. I didn't have to worry about chest pain, unless it was actively happening in the clinic which it never did. I didn't have to worry about shortness of breath or pneumonia, or, nobody's going to come to me and expect me to stitch a cut. I mean, there's so many things like that. So yes, it is very different. It is stressful. But there's a huge, huge learning curve. It's very steep. And for me, this is the beauty of the PA profession. I came out of a specialty in May, and in June I started training with my supervising doc. And Brandon, I told him, he's like, I know you were in sleep medicine, so how much or how little. And I was like, I need to learn how to suture like ground up, because the last time I did it was during rotation year in PA school, and he taught me ground up how to suture. I mean, obviously in the 12 shifts or so I worked with him, I didn't have all the training I needed. You have to, you just have to hope that you're going to see one type of every patient, but you're not going to, right? If I have any questions, I just call one of my docs. If Brandon's not available, I call one of my other supervising docs or one of my other doctors or providers, even the PA. I'll just run things by them, So it is nerve wracking, but I think it's a really, really great experience. So I think you do urgent care or primary care.
Just a couple more before we move on. I see a question in here that says, since your supervising physician is not present, do you have any kind of training or did you have to learn about the job / specialty through experience alone? And I know you just went into a little bit about how they gave you like a refresher before you hopped in, but was there any specific training that you had to go through in order to manage the clinic alone, or did you just kind of hop into it?
Yeah, I just kind of went into it. So yeah, I worked with Brandon for those few days, and then I kind of just like went into working on my own after that. And it was a good experience, but I mean, some days are stressful, and some days I am calling Brandon like if there's a patient actively having like an anaphylactic type of reaction, like I am calling Brandon every couple of minutes to give him updates. And that way, if there's anything I need to switch up, he can tell me, and that did happen, and so just being able to communicate, having a reliable supervising physician is also important. I mean, it's just as much their license as it is yours. So, and that's very, very practice based, it's very much based on your surroundings.
Mm-hmm. And just a few more. It says, you mentioned some specialties are saturated. Do you feel it is difficult to get a job right out of PA school? And have you found a field that is usually higher? Have you found that urgent care is a field that is usually hiring?
Urgent care is hard to get into as a new grad. It's hard to get into urgent care. Emergency medicine is very hard to get into. Some surgical specialties are hard to get into. So this is where PA school becomes very instrumental, because your PA school, your second year is your rotation year. So doing rotations in specialties that you're interested in is highly, highly recommended. And this is what I mean by PA schools attending or PA students attending like any virtual shadowing session, mine, this one, like kind of learning more about specialties, because maybe it's something of interest to you. And if it is, use your elective rotation to do a rotation in that specialty, because what happens is when you come out of school, if a place of interest that you're applying to asks about your experience, you can talk about how you did have that 5 weeks of training. I do count that as experience, so you can say, hey, yeah, I did an extra, for me, I did my elective rotation in pediatrics. I said, hey, I did an extra 5 weeks in pediatrics, and that's still better than the student that has never had exposure. Urgent care is typically not a core rotation in PA school. It's usually emergency medicine, primary care, as far as same type of practice is concerned. So you could do an elective in urgent care and show, hey, like I did an urgent care rotation. So they know that you're a little bit more familiar. With the saturations, I do think that those fields that are very saturated are hard to get into as it is, because they're so saturated with PAs, but they're harder to get into as a new grad. But there's the other side of it. How are you going to get experience if nobody gives you an opportunity, right? Mm-hmm. So, and some places understand that, and those are the places that will welcome you as a new grad.
All right. Thank you so much for addressing those. So if you want to continue on.
Okay. Let's see. All right. So perfect timing. This is the case study. This patient presented in my urgent care clinic, and let me actually see what day. She came in on the 17th. So this patient comes in, 28-year-old female, comes into the urgent care clinic. She has abdominal pain and she's concerned about a urinary tract infection. So her vital signs, this is part of what the medical assistant does when the patient first comes in, they triage. And so they're going into the room, they're asking all the basic questions and obtaining these signs. So vital signs, briefly here, all within normal limits. Pain scale 7 out of 10. I forgot to put on here sharp abdominal pain, started that same day. Her last menstrual period was on October 30th, a couple weeks before that. and her temperature was 98, and blood pressure, everything else was normal. And she did not look sick. Current medications, allergies, past medical history, surgical history, all part of what the medical assistant asked. Current medications, ibuprofen, she's taking for the pain. No known allergies, no past medical history, and no surgical history. So history of present illness. So for any of you that may not have ever seen like a patient note, there are 4 big components to the patient note. It's the SOAP, subjective, objective, assessment, and the plan. So the HPI is part of the subjective data. What is the patient telling you? What are their symptoms as they perceive them? That goes in history of present illness. So if you've ever read a medical note, it's the part that's basically a narrative written by the provider that basically gives a story of what brings the patient in. So in this case, this patient had a sudden onset of sharp cramping abdominal pain and pelvic pain, 7 out of 10 since 3 p.m. that day. There was no changes like in her food intake or medications. She didn't have any mechanism of injury or direct trauma to the abdomen, just kind of started. And then associated symptoms, nausea, vomiting, cramping, hematuria, meaning blood in the urine, dysuria, uncomfortable urination or discomfort when urinating. And she was spotting for the last 2 weeks, which she said for her is normal. She does tend to spot in between periods. So she had a really bad UTI, a urinary tract infection or bladder infection, in January, and she was hospitalized. And she comes in because it feels the same, and she's scared she's going to have to become hospitalized again. So she wants to get it checked out. No new sexual partners, no chance of pregnancy, not taking any birth control, and no history of sexually transmitted infections such as gonorrhea, chlamydia. She denies, and there was many other things, but denies fevers, chills, rigors, flank pain, like low back pain on either side that you may have associated with like a kidney stone. No frequency in urination. She didn't feel any urgency, felt some pressure down there to want to pee. Dyspareunia is pain with intercourse. She did not have any, and no changes to her bowel habits otherwise. So I don't know what part of your education you guys are all in necessarily, but does anybody in the chat have any guesses, or are they thinking anything?
I'll let you know. Sometimes it like lags, so it's like a few seconds behind.
Okay. So next thing is physical exam. So now I have a good history on her. Let's do an exam and see if we find anything. So this is what you examine on the patient. This is now, it's called the SOAP note. Subjective part, what the patient tells you. Objective is your physical exam, the lab data, all of that stuff, what you find. So general, she's non-toxic appearing, alert and oriented to face a person, place, and time. She's not confused or lethargic. The skin is normal, no rashes, respiratory, cardiac, both good. No weird signs or symptoms there. Her abdominal exam was abnormal, and I'll come back to that. Her genitourinary declined a pelvic exam in the clinic. This is not uncommon. Some people come in, know what they want, and they don't want anything else. All you can do is document it. You cannot force a patient to undergo any examination they don't want. This is similar to a male not wanting a hernia exam. I have had males tell me that. And so they will come back the next day to have a male provider do it. Nothing you can do about that other than document. The psych aspect, normal mood and affect, she was very pleasant. So going back to the abdominal exam, bowel sounds are great, and in all 4 quadrants. So the abdomen is divided into 4 parts typically. No CVA tenderness. So the CVA is in the back, right lower and left lower back. Typically you put your hand on the patient's back in that area. It'd be right over where the kidneys are. you put your hand there and you kind of like hit your hand or pound with the other hand. If they are tender or if they have a kidney stone, most frequently with a kidney stone, they will have a positive CVA tenderness. So you want to rule that out too, because even though she comes with abdominal pain, sometimes pain is referred to the front. Do you want to say something? Sorry.
Yeah, there was a lot of guesses for kidney stones, but the second biggest guess is ovarian cyst. See a
Okay.
lot of those, just want to let you know.
Okay. She had severe tenderness to palpation of the right lower quadrant. So if you're looking at somebody head on, you're looking at their stomach, or if you think about your own body, right lower quadrant. Okay. That's where her severe pain was. She was guarding that area, so didn't want me to touch it, didn't want me to palpate it. She had a positive Rovsing sign, obturator, psoas, and McBurney point tenderness. Any guesses there for anybody that's familiar?
Some people said appendicitis because of the abdominal sign. Some people are still guessing ovarian torsion.
Okay. Okay, so what do those signs mean? So the Rovsing sign is when you palpate the left lower quadrant, it causes pain in the right lower quadrant. So you palpate the left lower abdomen and they feel it in the right side. McBurney's point is if you feel your belly button, 2/3 of the distance going from your belly button to the right anterior iliac spine, so the pelvis, from the belly button to the pelvis, 2/3 of that distance, that's McBurney's point. That's typically where the appendix is. And she had positive McBurney point tenderness. She also had a positive obturator sign. So pain when you rotate the rotation of the right thigh. So if you have the patient lying down and you just ask them to turn their foot inward, or you hold their foot and turn it inward where you're rotating the thigh, they will have pain in that right lower quadrant. And the psoas sign, patient lies on the left and then the right thigh is flexed backwards. So you basically are extending the right thigh back. In this case, what I have patients do instead of lying on their left, because they don't want to move around a ton, I'll just have them scoot to the edge of the table and I'll tell them, I'm not going to let you fall off, but you're going to scoot like you're going to feel like you're falling off. Scoot to the edge of the table, drop your right leg off the table. And I just kind of like push it back. And that would indicate a positive sign there also in the right lower quadrant is also suspicious of appendicitis. Objective data. What can I do in an urgent care clinic? Every urgent care has something different. They don't all have the same like testing capabilities, things like that. So for urgent care, in our urgent care, we have a urinalysis, so we can do a quick urine dipstick. And we have the pregnancy, the HCG, which can determine a pregnancy. So we did her urinalysis, generally okay for the most part. A little bit of dehydration. She's got some blood in the urine. The leukocytes and nitrites are the two that are blood, leukocytes, and nitrites, usually classic for a urinary tract infection when they're all positive. Blood, fine, still possible of a kidney stone, still possible with kidney stone. Sorry, guys, I keep getting these notifications. So kidney stone is still possible with that. And the leukocytes infection, of course, it can indicate an infection, but that's a pretty low amount. I mean, plus minus, it's fairly right. Nitrites, negative, which, I mean, for the amount of pain that she's having, I don't believe, when I saw the urinalysis, I didn't believe it was just a UTI at this point, which is what she thought it was. Her pain is out of proportion. And of course, you can't rule out appendicitis. And she also came in at 6 o'clock, and my clinic was closing at 7 that day because we had a provider meeting. So not a whole lot I can do for her either to sit there and observe her, So urine pregnancy, positive, declined it to me, declined it to my medical assistant because she really had no idea. So that's something big we have to look into.
Lots of ectopic pregnancy. People are saying that guesses.
Okay. Let's see. So differential diagnosis. So what are all the diagnoses we're thinking of? In an urgent care, like I talked about before, urgent versus emergent. What is the most likely or most life-threatening to the least likely or least life-threatening? That's kind of what goes through my mind every patient that I see in an urgent care. And with COVID, those senses are even more heightened, right? So first on my differential, ruptured ectopic pregnancy. So yes, ectopic pregnancy on the right track. However, she also has severe abdominal pain. She also is spotting with a positive pregnancy test. So first and foremost, ruptured ectopic pregnancy. Second would be a ruptured ovarian cyst, also be in the similar, like same area. Third to me was appendicitis. Ovarian torsion was also on my differential. And I forgot to put that in here. And then the very, very least bit of her problem would be a cystitis or urinary tract infection, bladder infection. Disposition. So this is the most important decision. And it's kind of no matter where your setting is, but especially in the ER and urgent care and also primary care where you might see an emergency too. Disposition means what are you going to do with this patient? What's the next step for them? Do they go home or do they go to the emergency room, or do you just have them go home with the 24-hour follow-up? Can they go home and then, just come back in whenever they feel worse? Do they need a strict follow-up? What is the disposition? Is the patient stable? This patient was stable. Her vitals do show stability. Her physical exam, she's stable. She's just in a lot of pain. And what is the next step? In her case, it's the emergency room, no matter what it was, except for the cystitis, the bladder infection, all of those other things, definitely emergency room, because you have to rule out the life-threatening causes. And I can't do that. We do not have ultrasound in my clinic. We do have x-ray. I didn't keep her to do an x-ray at that point. But we do an x-ray would possibly show a kidney stone, but I didn't keep her for that. So that's the most important decision. Emergency room, of course, I sent her to the ER. And we are not connected. So I work in an urgent care that is owned by a hospital on island. So they just have a bunch of urgent cares all over the island and they're expanding. But because that merger just happened, I don't have access to hospital records. So if I want to know what happens with my patient, we call every patient that we send to the emergency room, we call the next day. Otherwise, we call 2 days after your visit if it was just a regular visit. So I know she would have been called the next day anyway. So I just waited. And if we were not going to reach her, if we wouldn't have reached her the next day, I would have called again at some other point. But I always like to follow up with these patients just to know if your suspicion is correct. So what is an ectopic pregnancy? Normal pregnancy, fertilized egg implants on the uterine wall. So about 300 million sperm enter the vagina during intercourse, and they'll either flow out, they'll die in the acidic environment in the vagina. Sperm passes through the cervix into the uterus. And the uterus destroys many sperm because it considers the sperm as invaders. Half of the sperm travel to the fallopian tube where the unfertilized egg is present. A few dozen of the original sperm, the 300 million, remain by the time they reach the egg. And then one sperm burrows into the egg, or the sperm burrow into the egg, and then the first one to make contact will fertilize. So that's a normal pregnancy. And then it implants, the fertilized egg comes into the uterine wall. Ectopic pregnancy is where the fertilization occurs and implants elsewhere. The egg implants elsewhere. Fallopian tube is the most common. So it could implant in the cervix, the ovary, the tube, or the abdomen. The embryo develops and grows in areas that are not meant to strain. So if you look at the tubes, of course, this is not to scale, but if you look at tubes, I mean, not every structure in the body is meant to expand. So the tube is not very elastic. And it's usually detected during the first trimester. And it can be life-threatening if it goes undetected because the tube can rupture and cause internal bleeding. what happened to my patient. So ultrasound, no IUP visualized. So this is in follow-up. I spoke to the hospital staff. I called because she didn't answer the first time we called for follow-up. So I spoke to hospital staff after that. And part of it's from them, part of it is from her when I was able to get a hold of her. Ultrasound, no intrauterine pregnancy. So if somebody is pregnant, you should be able to see a gestational sac in the uterus on ultrasound. There was no IUP visualized. A CT scan was done to rule out appendicitis. They noticed a hemiperitoneum, which means they noticed some blood in the abdominal cavity, but the ultrasound didn't show any source of bleeding. They couldn't find a source of bleeding. She did end up having, so they kept her for observation. She ended up having a 2-point decrease in her hemoglobin. So she had some blood loss somewhere. So she was hemorrhaging somewhere. And that's probably what was causing her pain, along with the fact that there was a confirmed ruptured ectopic pregnancy. So in the setting of not knowing where the hemorrhage is coming from, they decided to do a laparoscopy. So they didn't cut her open completely, but if so they start first laparoscopically with cameras inside. So she probably had maybe 3 or 4 small incisions. If they were not able to find the source of that bleeding and the source of her pain with that, they would open her up. So it's still a possibility, but there's no way to know until you're actually in there. And she ended up having a right-sided salpingectomy as a life-saving measure. So they took out her right fallopian tube because she had a ruptured ectopic pregnancy. So she was discharged after being observed for about 12 hours, and it was instructed to follow up outpatient with an OBGYN. The products of conception will continue to shed for some time. So she'll have some bleeding. She might have some chunks and clots that come out. Those are just residual products of conception that are there from her being pregnant. She came to the clinic 5 days after her procedure, and she just came in just to say thank you for the care that she received, because I mean, patients don't know, right? That's why we're here. That's why we're here. So, and to her, the spotting was no big deal because she spots in between periods, So, that was that case. Treatment options, like we kind of covered, surgical versus non-surgical. How do you decide? Surgery for ectopic pregnancy rupture. When you're ruptured, if it's ruptured, you're going to have some internal bleeding. So that is going to be treated surgically. Hemodynamic instability. In her case, it sounded like she was kind of on her way there with the drop in her hemoglobin. So again, for her, it would indicate a surgery. And then she had intraperitoneal bleeding as well. She had a hemiperitoneum, meaning bleeding in the abdominal cavity. Non-surgical options, methotrexate is a medication that you can give to terminate a pregnancy. If there's no intrauterine pregnancy seen and you're suspecting an ectopic, but no suspicion of like a rupture, so you wouldn't have the severe or persistent abdominal pain with that. The internal bleeding, of course, signs of infection. And yeah, so that would be non-surgical options would be for patients who are not, going downhill with the rupture. Any questions?
Yes. So a question I see in here was, how far along was this pregnancy and why did they have to remove the entire fallopian tube instead of, just like fixing the bleeding at the source?
Yeah, so that's a good question for a specialist for exactly why they remove it. But my guess would be, I mean, at a certain point that tube is ruptured. I mean, we're assuming that it probably ruptured that day or maybe the night before. I mean, we don't know how long it was open like that. But that's usually the mainstay treatment versus repairing it, would be just removing it. They kept the ovary because there was nothing wrong with it, but they removed the tube. And for her, I think she told me, and I don't think she was told exactly how much. I think the cutoff was 14, so somewhere she was less than 14 weeks along. She did have a period 2 weeks prior, but some people do bleed with pregnancy too.
So another question I see in here was, how common are ectopic pregnancies? Do you know?
No, I don't know how common they are. I mean, if I had to guess, I would say I don't know, maybe like less than 10%. That's what I would say, but I don't know for sure.
Yeah, I actually looked it up and it says according to American Academy of Family Physicians, ectopic pregnancies occur in about 1 out of every 50 pregnancies. So
Okay.
20 out of 1,000. So
Yeah. So like
yeah.
2%.
Someone asked, what happens to the ovary in this case?
It just stays. The
Okay.
ovary just stays there. Hmm.
Mhm.
So it doesn't prevent her. It doesn't prevent her from getting pregnant again. It's just that you're relying on the left tube, the left ovary and the left tube, you know. So it does not prevent her from getting pregnant in the future, but it will be more difficult, or maybe not. I mean, maybe she'll get pregnant the first time she is actively trying. Maybe, you know. But could could it could it cause delays? Possibly, of course.
Mhm. So there was a question. Have you ever had a case with dealing with race in the workplace where a patient was um, racist towards you or a coworker, and how would you deal with a situation like that?
I've never dealt with that. I've never dealt with racial discrimination. I have dealt with discrimination as a PA and not being a physician. So I can talk about that. Racial, no. I also live in a place that's very, very inclusive. Hawaii is a huge melting pot, like New York City or many other major um, cities. But I did have patients, like I've had off the top of my head, I can think of at least three that said, like one told me that she'll get my recommendation because she was already going to have to pay for the visit since I came in the room. But she is going to follow up with her primary care and get a second opinion. She was very open about that. The crazy thing is she was a pharmacist, so she herself is a healthcare provider. And so she knows that she's a healthcare professional. And so she knows what a PA is, but you can't change people's minds. Um, the second one walked out before I came in because he asked the medical assistant who the provider was, and she told him that it was a PA. And I do like I make sure my medical assistants know, like if they go out of their way to ask you if it's a physician, nurse practitioner, PA, do not let them mistaken me for a physician. You know, I don't want anybody to ever feel like they saw a physician or that they saw a PA or they saw a nurse practitioner when that's not in fact your title. I don't believe in that. I do believe in full transparency when it comes to your health, especially. So I do tell them, like, let them know. Of course, I'm going to do my part. I'm going to go in and I'm going to educate the patient. But my PAs, my PAs, my MAs, I've also educated them to explain this is what my role is and what I can do for them. And so I will tell you more often than not, the patients that do ask, like, is this a physician or a PA or whatever? Most patients will be like, okay, yeah, just wanted to know, and that's it. These three cases, I mean, I've seen hundreds and hundreds of patients since I started, and this is three people. So the other two both ended up walking out before I even went in to see them.
That's kind of crazy, like that
Mm-hmm.
this still happens,
Mm-hmm. It
especially
does happen, and
for
there's just a lot of awareness, of the PA
Mhm.
profession. It's one of the biggest things that we deal with as PAs, but it's definitely getting there. I think COVID really helped in that sense because PAs were amongst many, many frontline workers. I think the nurses are the MVPs, but PAs were definitely on the front line. I mean, pulled from any specialty. You have a dermatology PA that becomes an ICU PA overnight because they can. Your training allows for it. So I do think that COVID really kind of probably like opened people's minds. I think who may have otherwise not known what a PA was, or maybe wasn't open to the PA profession.
And just before we wrap up real quick, there's like really good questions I see in here. Just switching up gears a little bit, can you talk a little bit more about what you did as a sleep medicine PA?
Yeah, so I manage CPAP, BiPAPs, patients on CPAP and BiPAP. I did initial consultations. So they would come into the clinic, have these, they're referred because they have like other, heart related issues or history of a stroke or irregular heart rhythms. Those are all closely tied into sleep medicine. or they just don't sleep. They wake up, they sleep like 7, 8 hours, they wake up and they're still exhausted, or they're falling asleep during the day, or they're just really, really tired, snoring, and all of that stuff. So I managed, like I did the initial consult, I ordered the sleep study, and then I would have them follow up with me after the sleep study to discuss the results. And then I'm having them follow up once they're on the CPAP machine to make sure that they're doing okay and that their apnea is well managed.
Mm-hmm. So just going back a little bit more, would you recommend a gap year between undergrad and PA school? And if so, what type of things do you recommend doing during a gap year?
So I took a gap year, and I ended up doing, I had two because I didn't get in after the gap year. So I ended up doing, I did more upper level science classes. I gained more shadowing experience, more work experience, like patient care stuff. And I retook any classes that I might not have performed in well the first time. And then those are the things that I would recommend doing. I also took the time to refine my personal statement, and refine my overall application, enhancing it, making sure that it's the strongest that it can be. And then when that still didn't work, I did the master's, my second gap year. And that really, really helped. But of course, it's a financial commitment. And definitely, even a master's, it doesn't guarantee admission into a PA program, right? So I don't recommend everybody jump to a master's degree and put yourself in that financial hole before PA school. But I do recommend, if you want a gap year just to kind of decompress from undergrad and like gain life experiences, go on mission trips, do whatever. Of course, this is pre-COVID. I do recommend doing that. I think that you go from undergrad straight to PA school and then straight to work. Take a year for yourself. I mean, nobody's going to look down upon it. Be able to show that your experiences and what you've done in the last year is going to make you a better applicant and a better PA in the future.
Mm-hmm. I would just like to thank you so much for taking the time out to talk to us. And unfortunately, it is getting late. So if you guys have any additional questions, I will link her Instagram handle in the comments so that you guys can check that out. Here, I have, it's at ap.the.pac, like she's been talking about before. So if you guys have any questions, if she has time, she'll like reply to your guys' DMs, of course. And again, just thank you so much for taking the time out to do this. So I'd like to talk to you guys a little bit about next week. So next week we are going to have a pediatric oncology nurse. That will be on Monday, November 30th. And we will go from there depending on how things turn out with our speakers due to it being the holiday season. So that's kind of up in the air, but we will most definitely be informing you guys what will be going on over Instagram. So make sure you guys keep up with that. Just again, thank you again, Archana, and we will see you guys all next week. Good